So hello everyone, my name is Ridhimaa and in today's session we are going to learn about excretory products and their elimination. So basically whatever metabolism our body performs or whatever food we ingest, some of it is utilized by our body, right? But some of it is just like a waste for our body. Now these wastes get accumulated and these have to be excreted out of our body. So these are called nothing but excretory products. Now excretory products are also called as nitrogenous waste because they have nitrogen in it. Now excretory products are basically of three types. First is ammonia, second is urea, and then comes uric acid. Now ammonia is the most toxic substance, okay, while uric acid is the least toxic. Now ammonia being the most toxic, it requires maximum amount of water for its excretion, while uric acid requires minimum amount of water for its excretion. Now those who can afford maximum water loss excrete ammonia, while those who want to preserve water in their body, they excrete through uric acid. Okay, now those who excrete ammonia are called as ammonotelic animals. Those who excrete urea, ureotelic, and those who excrete uric acid, uricotelic. So bony fishes, aquatic amphibians and aquatic insects are ammonotelic in nature. Now this ammonia is excreted through diffusion, by diffusion method through the gill surfaces. So kidneys do not play any significant role in its removal. This statement is important. It is asked in assertion reason type of question. Now, mammals, many terrestrial amphibians and marine fishes excrete urea. So we are ureotelic animals. Now the the ammonia present in our body through the metabolic process, that ammonia is converted into urea by liver. So liver is the organ which converts ammonia into urea, and now then this urea is excreted through the kidneys. And reptiles, birds, land snails and insects excrete uric acid. So they have minimum loss of water. Okay, now for excretion, human have kidneys. Likewise, many other organisms have other different structures for the excretion. So Protonephridia or flame cells are excretory structure in Platyhelminthes, rotifers, some annelids and cephalochordates like Amphioxus. Nephridia are in earthworms and other annelids, while Malpighian corpuscle or Malpighian tubules are in insects including cockroaches. Antennal gland or green gland are present in prawns. Now these examples of excretory structures and the examples of the ammonotelic or ureotelic, uricotelic are frequently asked in MCQs. So you should be thorough with this. Okay, coming to the human excretory system. Now we all know human excretory system consists of a pair of kidneys, a pair of ureters, urinary bladder and a urethra. So our kidney is reddish brown bean-shaped structure situated at last thoracic to third lumbar vertebrae. Okay, so thoracic vertebrae, how many we have? We have 12 thoracic vertebrae while we have 5 lumbar vertebrae. So the kidney is situated at T12 to L3 level. Okay, now the measurements are important, that is 10 to 12 centimeter in length, 5 to 7 in width and 2 to 3 centimeter in thickness with a weight of 120 to 170 gram. These measurements are also directly asked in MCQs. Coming to the kidney. Okay, now on the inner side of the kidney we have hilum. Through this hilum, renal vessels, renal nerves or the ureter pass. Now inner to the hilum we have pelvis. Now this pelvis give projections called as calyxes. Okay, now kidney is again divided into two parts, that is cortex part and the medullary part. Medulla have medullary pyramids. This triangle shape are nothing but medullary pyramids. Cortex extending a bit between medullary pyramid is called as renal column or column of Bethany. Now you can see that the kidney is surrounded by a capsule. Okay, now this artery vein Now here by the color code of red and blue, you can clearly say that which is artery and which is vein. But in the exam paper, the diagram will be colorless. So therefore, you should know that uppermost is labeled as renal artery in your this diagram. Okay, so this diagram should be thorough. Uppermost is renal artery, lowermost is renal vein, while this is the ureter. So they will just give a colorless diagram. They will say that what is A, what is B. So you should know that uppermost is artery, lowermost is vein. Coming to the nephron. Nephron is a cell of kidney. It is the functional unit of kidney. Now, nephron again has two parts. That is the malpighian corpuscle and the tubular part. Malpighian corpuscle has glomerulus and Bowman's capsule, while tubular part has PCT, DCT and Henle's loop. Okay. Now, coming to the glomerulus. Coming to the glomerulus first. Glomerulus is nothing but a tuft of capillaries, tuft of afferent and efferent arteriole. So you can see afferent arteriole comes, afferent means blood is coming through it. Blood comes here, afferent arteriole, it becomes a tuft and then leaves through efferent arteriole. These efferent arteriole further forms peritubular capillary. Okay, it further forms peritubular capillary and this peritubular capillary further drains into renal vein. Okay, so this tuft is nothing but glomerulus. Next comes Bowman's capsule. Bowman's capsule is a double wall cupped like structure. So this surrounding the glomerulus is our Bowman's capsule. Now Bowman's capsule along with glomerulus is called as malpighian corpuscle. Then we have PCT. PCT is proximal convoluted tubule. Proximal means nearby. So the nearby convoluted means round, coiled. So the nearby convoluted tubule is a PCT. Then we have Henle's loop. Henle's loop is again divided into descending limb, the one which goes down, and then the ascending limb, the one which goes up. So this is a hairpin like structure. Okay. Then this you can see it is the DCT, distal convoluted tubule. Distal means far away. Then we have this called as collecting duct. Collecting duct, now many DCT of many nephron join a single collecting duct and then this single collecting duct come and go into the renal pelvis part. Okay, got this? So the malpighian corpuscle, PCT and DCT of the nephron are situated in the cortical region, while the Henle's loop dips into the medulla. Now based on this again, nephron is divided into two parts. That is the cortical nephron and the juxtamedullary nephron. Cortical nephron, as the name suggests, that the Henle's loop is situated at the cortex level, while in juxtamedullary nephron, the Henle's loop lie deep inside the medulla. Okay. Now, vasa recta is absent or highly reduced in cortical nephron. Now, vasa recta is a branch of, is an artery which is a branch of peritubular capillary. Okay. Now, vasa recta supplies deep in the medulla region. So, deep in the medulla region, juxtamedullary nephron goes. So, therefore, vasa recta are present in them but are absent in cortical nephrons. Urine formation. Okay. Urine formation in human beings takes place through three processes. First is glomerular filtration. Second is reabsorption. Third is tubular secretion. Now, glomerular filtration again takes place in three parts. First, see, the capillaries, we have the endothelium of the capillary. This is the endothelium of the capillary. Then we have a basement membrane. And then we have the epithelium of the Bowman's capsule. So these together performs as a unit and then they drain the plasma. Okay, so through the afferent arteriole, blood comes to the kidneys. Okay, so how nearly 1100 to 1200 ml of blood is filtered by the kidneys per minute. Okay, so 1100 to 1200 ml of blood enters the kidney per minute by the afferent arteriole. Now then, when it comes to the glomerulus, it goes and penetrates endothelium first, then the basement membrane, and then the epithelium. So 3-step process is there. So this is also called ultrafiltration. Now epithelium consists of podocytes. Podocytes are nothing but the cells of the epithelium. Now suppose this is the podocytes. There is a space here. These are called as slit pores through which the plasma enters. Now the filtrate that is formed. Blood comes through this, blood passes, and then whatever comes in the PCT is the filtrate, right? Now the filtrate form has nearly all constituents same as the plasma, but except that it does not have plasma proteins in it. It does not have plasma proteins in it. Plasma protein bear negative charge, and the endothelium, basement, and epithelium also bear a negative charge protein. Therefore, plasma proteins cannot enter or cannot get filtrate through this barrier because they repel. Also, this is the one reason, and the second reason is also that the plasma protein may be in bigger size than the pores in the barrier. Okay. GFR is nothing but the amount of filtrate formed by the kidneys per minute. Okay. So plasma comes in the glomerulus, and whatever filtrate is formed, it is a so blood or plasma enters into the glomerulus. Through the glomerulus it gets filtrate. Obviously all the blood, all the plasma will not get filtrate. Some of them, only some part of it will get filtrate, right? So that filtrate per minute is called as GFR, that is glomerular filtration rate. It is 125 ml per minute or 180 liters per day. The unit, please remember it very well. Okay. Now the kidneys have built-in mechanism for the regulation of glomerular filtration rate. Yeah. Now if the GFR falls, then kidneys have the mechanism to increase the GFR, while when the GFR is excess, the kidneys have the mechanism to decrease it. How is the mechanism is not given in your NCERT right now, and it is also not necessary for you to know. In the first 2 MBBS you are going to learn this, but in short I'll just explain. So if GFR falls down, okay, then there are some vasodilator factors in the renal artery which get released, and these vasodilators dilate the renal artery. So if the artery gets dilated, more amount of blood will flow through it. If more amount of blood is flown through it, then the GFR will automatically increase, right? Also, if the this is first the artery ka level ka mechanism. Also, we have renin secretion if the GFR falls down. Then if the GFR increases, then the arteries will secrete vasoconstrictor factors. These vasoconstrictors will constrict the artery. So if the artery gets constricted, blood will not flow. If the blood will not flow, GFR will come back to the normal. These are the mechanism. Okay. Now JGA apparatus or JG cells. JG apparatus is juxtaglomerular apparatus. It is formed by cells of distal convoluted tubule and the afferent arteriole. Okay. Now, a fall in GFR can activate the JG cells to release renin. I said it here. Now, how this mechanism works, we will do it later. Now, a comparison of the volume of the filtrate formed per day, that is 180 is formed filtrate, but the urine formed is 1.5 liters. So this indicates that almost 99% of the filtrate is absorbed. So nearly 99% of the filtrate is reabsorbed in the kidneys back. Now how it is reabsorbed? So this is the second step, that is reabsorption. Now some substances are reabsorbed actively by the active process, while some are done passively. So glucose, amino acid, sodium are reabsorbed actively, while nitrogenous waste are absorbed passively, and the water is also passively absorbed in the PCT, that is proximal convoluted tubule. Okay. Now this active ones you should remember, they are asked frequently. Now is third step is tubular secretion. Okay, some waste that are needed to be excreted, if they are not passed through the glomerulus, then how can they be excreted? So, okay, coming here. If the waste, suppose I have something that I need to excrete it out, but it does not passes through the glomerulus, then it goes to the efferent arteriole, and through the efferent arteriole it goes to the peritubular capillary, and then through the peritubular capillary it gets excreted. It secrete the substance or the waste in the PCT or DCT, any of them, and then it is carried forward in the urine. Okay, so this is tubular secretion. So excretion takes place in glomerulus form also and tubular secretion also. So H plus, K plus and ammonia are done by tubular secretion. Functions of the tubule. First tubule is PCT, that is proximal convoluted tubule. It is lined by simple cuboidal brush border epithelium. Why brush border epithelium? Because it increases the surface area of the reabsorption. Now, this statement, nearly all of the essential nutrients and 70 to 80% of the electrolytes and water are reabsorbed by the PCT. So, nearly all the reabsorption is done primarily in the PCT. Now, PCT also does tubular secretion of hydrogen and ammonium ions, and it also absorbs HCO3 from it. Henle's loop. Reabsorption is minimum in ascending limb of Henle's loop. Now, descending limb is permeable to the water. Descending limb is permeable to water, and ascending limb has two parts, the thick part and the thin part. The thin part of ascending limb is permeable to NaCl. Entire ascending limb is permeable to NaCl, but the thin part, the permeability is done through passive process. NaCl is reabsorbed by passive process, while in thick part NaCl is reabsorbed by active process. This you have to remember. Okay, DCT, conditional reabsorption of Na and water. Conditional means what? Now I have two hormones, that is ADH and aldosterone. When these hormones act on DCT, then the DCT will reabsorb. Okay, conditional means on a situation, if something conditional means शर्त पर. So शर्त क्या है? ADH and aldosterone release करो, फिर ही DCT से Na का reabsorption होगा. So शर्त is releasing ADH and aldosterone first. So conditional means this thing. Okay. DCT also reabsorbs HCO3 and secretes potassium and hydrogen ion and ammonia to maintain the pH. So our PCT and DCT both reabsorb HCO3 and both secrete hydrogen, potassium and ammonia for pH maintenance. Okay. So this is the descending limb, permeable to water passively. Thick segment and thin segment of the ascending limb. Thick segment NaCl are permeable but by active process. Thin segment permeable to NaCl but by passive process. This is asked. Okay. Now some amount of urea is transported by the collecting duct into the ascending limb. This is very important. Sometimes the figure is given as it is and they just label this as A or B or C, and then they ask what is the A or what is C, something like that. Collecting duct. Collecting duct, large amount of water could be reabsorbed from this region, providing the concentrated urine. Some amount of urea flows into the medullary interstitium to keep up the osmolality. This line I will explain later. It also plays a role in maintenance of pH by selective secretion of H and K+. So the upward arrow shows reabsorption, while the downward arrow shows secretion. So the substances you should know, because they will label them as A, B and C, and then they will ask what is A, what is B, or is it correct or something like that. So this diagram is important. Mechanism of concentration of the filtrate. Okay, so mammals have the ability to produce a concentrated urine, and to produce this concentrated urine, Henle's loop and vasa recta play a major role. Now, for this concentrated urine, we need a osmolarity in the medulla. Now, why this osmolarity is necessary? Suppose this is a Henle's loop, and everywhere in the interstitial space in the medulla outside, everywhere the osmolarity is 300 milliosmol per liter, while the filtrate passing also has the same osmolarity. Now, even though the descending limb is permeable to water, if there is no gradient, if there is no concentration gradient, will this water flow passively Of course not, right? So therefore, will the concentrated urine be formed? No. So therefore, the osmolarity is required in the medullary region. Now, how this osmolarity is formed? Okay. Same example. The 300 milliosmol filtrate comes here. Everywhere the osmolarity is same, that is 300. So water obviously does not comes out. But here in the ascending limb, we have channels of NaCl. So as the filtrate pass, the NaCl flows out from these channels, and then thus this increases the osmolarity from 300 to 400, 500 and so on. So deep down in the medulla, the osmolarity is around 1200, while that in the upper part of the medulla we have 300 milliosmol per liter osmolarity. Why that deep down in the medulla the osmolarity is highest? Because see, the filtrate, the NaCl channels present here down in the medulla will allow maximum amount of NaCl to flow outside, right? Because more NaCl is present at that time. Now here up the channels, when this filtrate pass up, already some amount of NaCl is flown outside, right? So the NaCl remained to pass through the upper channels is less. So obviously the osmolarity there will be less. Okay. Now how this acts? We saw why osmolarity in the medulla is necessary. We also saw how the osmolarity is how the osmolarity is formed. Now how this osmolarity is maintained is again another part, right? Now suppose this is my Henle's loop and this is my vasa recta. Now Henle's loop, this is descending limb, this is ascending limb. Suppose this is a descending limb of vasa recta and this is the ascending limb of vasa recta. So it is in opposite direction like that. So therefore they are called counter current mechanism, or they are counter to each other. Counter means opposite. So they are counter to each other. Now here the osmolarity is 1200 and here it is 300. Now see, the plasma, the filtrate passes through this while the blood is here. Now when the plasma flows, due to osmolarity differences, water comes out, right? So if water comes out and only electrolytes are remained in the filtrate becomes concentrated. So the concentration here rises. Now when the filtrate passes, due to the concentration difference again, the NaCl is reabsorbed in the medullary space. Okay, so here the concentration of the urine becomes dilated. The NaCl passes out. Now this NaCl, which is come in the medullary space, is absorbed by the vasa recta. So eventually the vasa recta's concentration becomes high, the osmolarity becomes high. So till here the osmolarity of the vasa recta becomes high till this space. When it goes up here, water from the descending limb of Henle's loop come in the vasa recta. So the blood again becomes dilated. So blood is also maintained, and the excess of NaCl which comes out is also taken out by the medulla. So the osmolarity is also maintained in the medullary region. So therefore this mechanism is important. This is called as counter current mechanism. Okay. So through the descending limb, filtrate comes, then water will excrete due to the osmolarity difference. The filtrate becomes concentrated. As the filtrate becomes concentrated, at some point it becomes more concentrated than the medulla. So when it becomes more concentrated than the medulla, then excess of NaCl from the filtrate will flow towards the medullary region. Now we don't want this osmolarity of the medulla to become too high and too low. So this excess of NaCl which comes in the medullary region is taken by the vasa recta. So the osmolarity in the medulla is maintained. Now this NaCl goes into vasa recta, then the vasa recta becomes highly the osmolarity of the vasa recta increases, but vasa recta has blood. So do we want blood to be to have high osmolarity? No. So as the blood passes down here, then water from the descending limb enters into the vasa recta. So again it becomes dilated and comes back into the normal state, right? So the blood is also maintained, the osmolarity of the medulla is also maintained by this mechanism. Got this? I have explained this same. Okay. Human kidney can produce urine nearly 4 times concentrated than the initial filtrate formed. Now, regulation of kidney function. So the function of the kidney is regulated by hypothalamus, the JG cells and the heart. Okay. Now hypothalamus, near or in around hypothalamus we have some osmoreceptors. Okay, we have some osmoreceptors. Now excess loss of water through the kidneys stimulate these osmoreceptors to send signals to the hypothalamus to release what? ADH. Okay, so ADH is formed by hypothalamus, but it is stored in pituitary, posterior pituitary gland. So it sends signal to hypothalamus and thereby to the posterior pituitary to release ADH. Now this ADH goes and acts on DCT. We have seen this earlier. DCT have conditioned functions. So DCT पे ये ADH जाएगा और उस पे काम करेगा. So then what will happen? This DCT will start reabsorbing maximum amount of water through the filtrate. Now this reabsorbed water will cause the osmoreceptors to inhibit their signals. So then all the cycle is then maintained. Also ADH have constrictory effect in the blood vessel. So ADH will do what? They will constrict the afferent arteriole. So blood will not flow through the glomerulus. So therefore GFR will release. If GFR is released, then excess amount of water will not go, not be excreted out through the urine. Then the JG cells. The JG cells, they secrete renin. Okay. Now when there is a fall in GFR, so if GFR decreases, then the DCT sense the fall in GFR and then it stimulates the JG cells. JG cells are present on afferent and efferent arteriole. So they stimulate the JG cells to release renin. This renin converts angiotensinogen in the blood into angiotensin 1 and then to angiotensin 2. Now this angiotensin 2 has two effects. First, it will go to the adrenal cortex and stimulate the release of aldosterone. Second, it is a powerful vasoconstrictor. So aldosterone also will act on DCT and it will reabsorb water and NaCl. And vasoconstrictor effect is it will constrict the efferent arteriole. When the efferent arteriole gets constricted, then through the so blood comes from efferent arteriole, goes into glomerulus and then flows out to the through the efferent arteriole. Now if this efferent arteriole is constricted, then the blood will not pass to the efferent arteriole. The blood pressure in the glomerulus itself will increase, then the GFR will increase automatically. So GFR is increased. So this is called as RAS mechanism, renin angiotensin aldosterone mechanism. Now if GFR increases highly, then we have ANF, atrial natriuretic factor, to inhibit it. GFR increases, more amount of water is reabsorbed through the kidney. If more amount of water is reabsorbed through the kidney, then the blood will have more amount of volume. Okay, so water is absorbed and passed through the blood. So blood volume will increase. If the blood volume is increased, then the heart have some stretch receptors. So volume increase ho gaya, blood volume increase ho gaya. So if it goes into the heart, the contraction of the heart or the amount of blood in the heart, that will stretch the muscles of the heart because of the more amount of volume. Now this stretch will release an amount, release atrial natriuretic factor. This ANF will indeed cause vasodilation. This vasodilation will bring back the blood pressure. This will decrease the blood pressure. So this is a mechanism for renin angiotensin to act as a check on the renin angiotensin mechanism. Micturition, whatever amount of filter is formed, that is passed through the ureter to the urinary bladder and it is stored in the urinary bladder. Once the urinary bladder gets full, it sends signals to the CNS, to the brain, to evoke a voluntary signal for the dilation of the sphincters or the relaxation of the sphincters. So signal is initiated by the stretching of the urinary bladder. Obviously, due to the filling of the urinary bladder, there will be stretch, and this stretch will send signals. Now, micturition processes, about 1 to 1.5 liter of urine is excreted per day. It is yellow colored, watery fluid. pH is 6, that is slightly acidic, and it excretes 25 to 30 gram of urea. Important. So this characteristics of the urine is asked. Now, a diagnosis of the urine. There are some tests. You may have listened about the urine test. So by analyzing the urine, if the urine has glucose in it, it is called as glucosuria. If it has ketone, it is called as ketonuria. And this is the symptom of diabetic mellitus. In diabetic patient, the urine will have glucose and ketone bodies present. Roles of other organs in excretion. Now, besides kidney, other organs like lung, skin, and liver also help in excretion of other substances. Lung excrete large amount of CO2, that is approximately 200 ml per minute, asked in the question paper. Now, liver excretes bile containing bilirubin, biliverdin, cholesterol, and steroid hormones, vitamins, and drugs. Now, these you have to learn, you have no option. Sweat secretes NaCl, small amount of urea, and lactic acid. The primary function of the sweat is to cool down our body. We get sweating only in hot seasons. Okay, so to cool down our skin, to maintain the body temperature, we get sweat. We have sweating. So the primary function of sweat is to facilitate a cooling effect on the body. Sebaceous gland excretes sterols, hydrocarbons, and waxes through sebum. These all examples you have to learn. These disorders of the excretory system. If there is a kidney failure, then there is accumulation of urea in blood. That situation is called as uremia. Now, in such situation, you have heard that hemodialysis is done. What is hemodialysis? Basically, it is a machine which contains cellophane tube. Now, this cellophane tube is there, and around that cellophane tube, you have a substance. This substance has same constituents as the plasma, except this substance lack nitrogenous waste. Okay, they do not have nitrogenous waste. Now, an artery from your body is taken, and blood from it is added to the cellophane tube. So the blood passes. As the blood have nitrogenous waste, but the substance around do not have nitrogenous waste, the nitrogenous waste comes out of the blood by the concentration gradient, and thus a cleared blood is obtained, and this cleared blood is drained into one of your veins back into the body. So when the artery is being pumped into the cellophane tube, heparin is added to prevent coagulation, and then when it is added back into the vein, antiheparin is added. Okay. Renal failure, the treatment is transplantation of the kidneys. So kidney is taken from close relative to avoid the chances of rejection. Renal calculi is nothing but kidney stones or insoluble masses of crystallized salt, that is oxalates, and glomerulonephritis is the inflammation of the glomeruli of the kidney. So this is just a basic thing, and whatever I have marked are all important and asked directly in the MCQ. The as it is sentences are asked. So be prepared with it, and I hope you all have understood this. This is again in your first year MBBS classes, so you will learn it further again.